I would like to express our sincere gratitude and thanks to Endocrinology Society of India and especially Dr. Sanjay Kalra, Dr. Ganapati Vantiva, and Dr. Rakesh Sahai for their guidance and support in organizing this webinar. With this, I would like to hand over the session to Dr. Sanjay Kalra. Thank you, sir.
A warm welcome to everybody who has joined in. We are here to discuss the adrenal gland. Now, these adrenal glands are very small. They just weigh 3 grams each. But without these 3 grams, I think nobody can survive. You can survive after a myocardial infarction. The heart weighs 250 grams. Even if 200 grams of it gets destroyed, gets necrosed, life will continue. You can survive without a spleen that weighs 200 grams. You can survive after a nephrectomy. Each kidney weighs 150 grams. But what is it that evolution has packed in this 3 grams of adrenal tissue without which we cannot work? It's good to know physiology, but we should also know pathology. And the adrenal gland works in mysterious ways. One of our panelists today is a very senior person from Bolivia in South America. In Bolivia, an American anthropologist created the term hypoglycemia aggression hypothesis. He studied an Indian tribe, not an Indian, but an American Indian tribe. And he found that in that particular tribe, the aggression level was high. Now, the aggression level may have been high because they didn't like the American colonizers. That is a separate matter. That's a confounding matter. But he actually went and checked glucose in that particular tribe. And then he checked glucose in the surrounding tribes. And he found out that this particular tribe had a lower glucose level. So he felt that they were aggressive because of hypoglycemia. The same thing happens to us in our clinics also. At the end of a busy day, towards the end of a busy day, you tend to get a bit short-tempered. You become a bit cranky. Early morning, you might have motivated a lady to take insulin. The same lady, the same insulin, the same glucose values. But towards the end of the day, you yourself become aggressive. Your patients become aggressive. And you end up writing an oral hypoglycemic and telling the lady, come back next week, but please come back at 9 a.m. Let's talk again. That is hypoglycemia aggression. At the very other end of the spectrum, we have hyperglycemia. And that is where the adrenal gland hormones actually have an important role to play. So in today's webinar, in today's epic webinar, we'll talk about the adrenal gland and diabetes. We'll talk about adrenal diabetes. And let's see the various permutations and combinations, the various nuances of the interrelationship between glucose metabolism and adrenal physiology. To do this, it's a great pleasure to introduce Dr. Beatrice Ann. Dr. Beatrice is Associate Professor at Hyderabad, at NIMS Hyderabad. And she's one of the most dynamic Indian endocrinologists today. She has won virtually every prize there is to win. And I do remember asking Beatrice, did you leave anything for the poor little boys to win? So she said, yes, sir. I left all the silver medals for them. So that is what happens when you're with Beatrice. And apart from all the other things that she's doing in our country, she is also author of a chapter in one of the most prestigious endocrine textbooks today, that is Endotext, which is published in the US. So Dr. Beatrice, warm welcome, and please carry on with the proceedings.
Thank you, sir, for the kind introduction. Very good evening and a warm welcome to all of you. We are in fact very excited to have you all today for this very interesting discussion on adrenal diabetes. So let me introduce my co-moderator today, who needs no introduction. In fact, Dr. Sanjay Kalra. He has done his DM endocrinology from the very prestigious AIIMS, New Delhi. He's a consultant at Bharti Hospital, Karnal, and he's also visiting professor at AIIMS, Rishikesh. He's the immediate past president of the Endocrine Society of India. He's the vice president of South Asian Federation of Endocrine Societies. He's the education editor, International Society of Endocrinology. He's the Deputy Chair, Advocacy and Partnership Working Group in ICE. And he's a member, Program Organizing Committee in the International Congress of Endocrinology, which is to be held in Singapore in 2022. He's the section editor of endocrinology in API Textbook of Medicine. He's the section editor of Tropical Endocrinology, Endotext, the PubMed Index textbook. And his hobbies are the traditional Haryanvi, Mugdar, and the Bhangra. We welcome you, sir. And sir is, in fact, one of the nicest person that you can meet. A very approachable, a wonderful teacher. Welcome, sir. And let me introduce our speaker for the day, who's again a very prominent figure in Indian endocrinology. a very charming and wonderful speaker, Dr. Arundhati Dasgupta. She is a director and consultant endocrinologist at Rudraksha Super Specialty Center in Siliguri, West Bengal. She has received the A.V. Gandhi Award in 2012 for the best thesis. She's also received the Diabetes Awareness Initiative Award in 2018, and she has done more than 180 awareness programs on endocrine disorders across West Bengal, Sikkim, Bihar, and Nepal. And she's a course coordinator for PHFI and several other national and regional training programs. She's done multiple presentations at national and international platforms, and she has several national and international publications. And she's also contributed as an author several chapters in many books. Thank you, ma'am, for being with us today, and a warm welcome to you. And let me introduce our chairpersons and panelists for today. We have Dr. Douglas Villarroel, who has joined us all the way from Bolivia. He's the president of the International Diabetes Federation, the South American and Central American region. He's the editor-in-chief of Diabetes Voice from the International Diabetes Federation, and he's a member of the expert committee of the World Health Organization, the update of essential drugs in endocrinology. He's been president of the Bolivian Society of Endocrinology, Metabolism, and Nutrition. He's been co-president of the International Diabetes Forum, and he's coordinated the first transplant team led by Dr. Herland in the city of Santa Cruz de la Sierra for 10 years. And he's been a pioneer in the recruitment of organ donors in the same city. Wow, sir, a commendable job, I would say. He's been past professor at different national and international universities. And at the Bolivian Evangelical University, he has taught subjects for the nutrition. And at the Bolivian Catholic University, he has taught courses for the endocrinology career as well. We welcome you, sir, and thank you for joining us today. Our next chairperson is, again, a very prominent figure in Indian endocrinology, Dr. Raman Boddula. He's a senior consultant and head, Department of Endocrinology at Yashoda Hospital, Secunderabad. He's heading the DNB endocrinology training at Yashoda Hospital, Secunderabad. And he's worked as consultant and head of Department of Endocrinology in KIMS for 5 years. And he's also worked as faculty in endocrinology in NIMS, Hyderabad for 1 year. He's been awarded the Vaidya Ratna Award from Suman Art Foundation in 2015. He's a fellow of American Association of Clinical Endocrinologists, and he's a life member of Endocrine Society of India. And he's also a member of the American Association of Clinical Endocrinology and US Endocrine Society. And again, he has authored various articles in national and international journals. He's very much loved by his patients and revered by his students. A warm welcome to you, sir. And over to Dr. Arundhati for the presentation.
So much, Dr. Beatrice. Just give me 1 second to share this point. So good evening, everybody. It's such a pleasure to be here in amidst this August panel and to be discussing on this topic, which is something that we generally know about a lot in theory, but in practice, at times we tend to miss out, because probably we are not keeping our, threshold of suspicion as low as we should keep it. And we'll just take you across a few cases where we'll try to look at some of those aspects where, you might have a patient with an adrenal cause of diabetes, and you might not be able to, diagnose it, or probably we are not diagnosing it as often as we should. Because if you look at the numbers, they are not that rare. But how many patients of diabetes do you diagnose with adrenal, disorders, unless they come in with very, very prominent symptoms, which is something very different. So we'll just go across a few cases and try to understand this connection better. So this is a patient, a 56-year-old woman with a 12-year history of hypertension, 4 years of diabetes, lumbar neuropathy, uncontrolled sugar, high BP, and she goes to her doctor always with a complaint of inability to lose weight. So she's been put on metformin 2,500, dapagliflozin. She's also on gliclazide, and then the other antihypertensive, 3 antihypertensives, as you can see. In spite of that, her BP is 149/100 at presentation. Her weight is 67, BMI stands at 29.8, and generally the other systems did not have much problems. So these are her reports: fasting, PP. You can see HbA1c at 8.6, creatinine a tad higher, 1.12. She had microscopic hematuria. So therefore, an ultrasonography was done, but as such, it did not reveal much. Then, because this hematuria persisted, she was asked to do a CT abdomen. And when she got a CT abdomen done, as was suspected for the hematuria, there was a calculus there. But at the same time, there was also another well-circumscribed, homogeneous 2.7 centimeter small mass sitting there containing a fatty component to the left adrenal gland, which suggested adrenal adenoma. Now, this was what it was. Now, this case actually is very interesting because it's a real life case. And she was, the doctor who was seeing her actually focused on the calculus, focused on the sugar levels, which were not getting controlled, told her about lifestyle changes, which she was following anyway. And then, asked her to go in for insulin. And he kind of overlooked into this aspect till she went to another doctor with her reports. And when the doctor saw this, he decided to investigate further. And when he investigated further for this adrenal mass, the baseline cortisol stood at 19. So the ONDST was done, which was at 7.78. The low-dose dexamethasone suppression test was also done, which was at 3.18. At the same time, the 24-hour urinary excretion of catecholamines and metanephrines were done. Aldosterone-renin activity was normal. So in view of the ONDST, the LDDST, the patient was diagnosed to have a cortisol-producing adrenal tumor. The tumor was surgically removed by a laparoscopic method, and the pathological diagnosis was that of an adenoma, which was 3.2 centimeters, 3 into 2 centimeters in size, without any evidence of malignancy. Now, if you just look back, this is incidentaloma per se, because she was not looking for, the doctor was not looking for anything in the adrenals. And therefore, because he was not looking for something in the adrenals, he missed out on the diagnosis at the first go. It was only after the second doctor had a relook that this thing came up, and eventually this cortisol producing adrenal tumor came. Now, after the resection of the adenoma, the patient's general condition improved. Her BP stabilized. She was on 3 medications, remember? She came down to, she could be tapered to 1 medicine. Her HbA1c came down to 5.3 after 5 months without medication, and she ultimately lost weight after so many months. So here what we are talking about is not a florid Cushing's. We're talking about, not a position where you're going to see all the signs of Cushing's. You are not seeing the stria, you're not seeing the hump, you're not seeing anything that you would generally expect to see in a florid Cushing's. We are talking about the subclinical Cushing syndrome and diabetes mellitus. A florid Cushing's would rarely be missed by somebody who knows about Cushing's, but generally subclinical Cushing's is something which is more often than not missed. And when we're talking about an excess of cortisol, we know that the effect that it has on the glucose metabolism involves a lot of areas, starting from the increase in the obesity to the inflammation increase, to the alteration in the leptin-adiponectin ratio, lipolysis, to increase glycogenolysis, increase in the insulin resistance per se, decrease in creatine, decrease in the beta cell function, decrease in the muscular glucose uptake, glycogen synthesis, and all those. So a plethora of pathophysiologies through which an excess of cortisol is causing a derangement in the glucose metabolism. Now, if you look at the figures, 20% of patients with adrenal incidentaloma have some form of subclinical hormonal dysfunction, and they actually represent a population at a higher risk for metabolic disorders and cardiovascular disease. So if you're treating the diabetes in these patients, that will not be essentially different from treating it in a patient who doesn't have a Cushing's disease. And the microvascular sequelae and their severe metabolic derangements are generally extremely rare. So having said that, when we look at this figure where you're looking at the overt Cushing's and you're saying that, okay, diabetes is there in 36%, and you're looking at a subclinical Cushing's and you're saying 22% of these patients have diabetes, the next question is, would it be worthwhile to screen all obese, hypertensive, diabetic patients for Cushing's? Now, there have been a number of studies done to this effect, but it has not been found to be very, very, the sensitivity level has not been found to be very high. The numbers that came out were not, not something that you could actually do it regularly, because our patients come to us, asking them to come back for the ONDST. Unless you have a very, you're quite sure about what you're thinking, doesn't really happen. Today we're talking about this. Tomorrow we might go and suspect that, okay, this might be Cushing, that might be Cushing's for every obese. But as things fade into the background, we generally tend to forget how many obese patients, unless they come per se for obesity, obese, diabetic, hypertensive, they form a vast majority of our patients. How many of them do we actually suspect to have subclinical Cushing's? So that is something that we probably need to rethink and reset the threshold of our suspicion. Our second case is a 33-year-old female with a 5-year history of hypertension. She's been a diabetic for the last 2 years. She was evaluated for abdominal pain. Now, she had uncontrolled hypertension documented during her primary visit. She did give a history of panic attacks. But then when you're talking about young females with panic attacks, when I'm discussing adrenal and diabetes, you would know where I am hinting towards. But in your OPD, when you look at the 33-year-old, maybe stressed female, and she's giving a history of panic attacks, you generally tend to pass it on, right? And then is this uncontrolled hypertension, and you kind of say that, okay, fine, decrease your stress, lifestyle, bring about lifestyle changes, this will go away. For these symptoms, because of her panic attacks, she had undergone cardiac evaluation, Holter monitoring, and echo, cardiac stress test, and nothing revealed anything. So she was kind of put into that category where she comes up with these problems on and off, and there's nothing much really to it. She's also had 2 pregnancies with uneventful vaginal deliveries. So this lady, BP was 170 by 100. There was tachycardia. She was on telmisartan and amlodipine and hydrochlorothiazide, something that a combination that we commonly put to our patients. The HbA1c was at 9.4, uncontrolled sugars, without ketosis. She was on double OHAs plus basal insulin, and creatinine was 1.2, dyslipidemia, ECG and X-ray were normal. Now, an ultrasound was performed for her abdominal pain, and that brought out a big, large adrenal mass. She underwent a CT scan, which identified an 8 centimeter heterogeneous enhancing left adrenal mass. The ONDST was negative here. Sodium was 132, potassium was 4.1, but the 24-hour urinary catecholamine level, as you can see, way above the normal range, as also the total metanephrine level. So patient was diagnosed as pheochromocytoma, and she's been having symptoms for quite some time. It required this abdominal pain to bring it into attention. Thankfully, this one was a big one, which came under the evaluation of an ultrasound. But had it been something which is not that prominent, then probably nobody would have gone ahead with the CT, and this diagnosis could have been missed. She underwent a left transabdominal open adrenectomy. Histology was pheo, and insulin drip was initiated perioperatively, but was stopped post-op. And post-op, she required minimal insulin, discharged without insulin or OHA. 2 weeks after surgery, 90 fasting, 140 pp. She became normotensive, no medications for hypertension, and no more panic attacks, quote unquote. Coming to case number 3. This was an interesting case, a 16-year-old presenting with a 6-week history of weight loss, thirst, nocturia, lethargy. Presentation, she was extremely unwell. She had tachycardia, BP was 170/100. Her urine was strongly positive for glucose and ketones. So the glucometer said high. The ABG said a pH of 7.3, bicarb at 23. Sugar levels extremely high, as you can see, 340, 598. The KFT, LFT, and others were normal. So she was started off treatment as a new onset type 1 diabetic. She was given basal bolus. BP was not stabilized with telmisartan and amlodipine. C-peptide came normal. Anti-GAT came out to be negative. The ultrasound, whole abdomen was normal. But in view of, I don't know what the reason of suspicion was, because this is a clinical case which I took from one of my friends, and the 24-hour catecholamine was done. In most of these cases, I can tell you, I think I'm speaking for most of us, you're seeing these patients, you're putting them on basal bolus, the C-peptide comes normal, and you're left wondering, and then the anti-GAT is also negative, and you're wondering whether the sample was correct, whether it was transported properly. But then you're sure, 16-year-old, this presentation, acute presentation, sugar levels that high, and then improving with basal bolus, you would think of type 1, you wouldn't think of anything else. But the doctor here, I don't know why, got this test done, and it came out to show an MRI with a left adrenal mass consistent with pheochromocytoma, 24 hours catecholamine, all showing raised level. And then she underwent adrenectomy, because she was diagnosed as pheochromocytoma, which was basically masquerading as a type 1 diabetes mellitus patient. After the adrenectomy, her insulin requirement rapidly tailored off, and after stopping insulin, an oral glucose tolerance test was found to be normal. So FeO and diabetes, we know the connections there. If we talk about, the connections between what is linking pheochromocytoma to diabetes, this has been, you just look at this paper, this is in 1966. And this is where they discussed about the two major influences on glucose metabolism, one being the glycogenolysis in the liver, and the other being, the glucose uptake. And then they spoke about the epinephrine, which might decrease the insulin levels. So this is way back there where they looked at the effect of epinephrine. And if you look at FeO per se as a whole, the pathogenesis is multifactorial because catecholamines, they act on the peripheral alpha as well as the beta adrenergic receptors widely expressed in the body, the pancreas, the muscle, the adipose tissue, the liver, and thereby they bring about impaired insulin secretion because of the raised hyperadrenergic tone of the pancreatic alpha and beta cells, inhibiting insulin secretion and stimulating glucagon, increasing the adrenergic receptor activation upon the adipose tissue, the muscle, and the liver to increase the hepatic and muscle glycogenolysis, as also the activation of the beta receptors, bringing about impairment of the peripheral glucose utilization by inducing insulin resistance at the post-receptor level. So these are the various effects, the various, the receptors and the effects that are brought about in the pancreas, in the skeletal muscle, in the adipose tissue, and in the liver, thereby all in all bringing about an increase. And interestingly, both insulin and epinephrine actually increase the presence of the GLUT4. However, when epinephrine and insulin are present together, the glucose transportation of GLUT4 is decreased, and the potential transportation capacity of the insulin-stimulated GLUT4 is also reduced and altered in the presence of high concentration of epinephrine. So is there a difference between epinephrine and norepinephrine secreting tumors? Yes. Epinephrine has a slight more edge to it, an increase in the blood glucose elevation than norepinephrine. And norepinephrine, it does cause an increase in the glucose production, but it also causes a proportionate increase in the glucose uptake, thereby not causing much significant hyperglycemia. And what happens to the insulin or OHA requirement post-surgery? These are studies that were pre-published way back. You can see, from 1983, 96, and then up to 2017, you can see what was there pre-operatively. These were the requirements pre-operatively to the tune of 52, 42 units per day, or even beyond somebody having a requirement of 110 units per day. Then post-operatively, most of them did not have an insulin requirement at all, or they were doing well with just metformin or metformin or an additional OHA. The fourth case in question is a 42-year-old male presenting with a 7-month history of polydipsia, polyuria, palpitation, a background history of 10 years of hypertension, not very well controlled, on triple drugs. So when at presentation, his BP was 150 by 100, the sugar levels were high, HbA1c was at 8.5. The others, as you can see, normal potassium was 3.1, fundus showed moderate retinopathy, ECG said LVH. So the patient was initiated on OHA, and the dose of the antihypertensive was altered. Subsequent visit, sugar levels have come down slightly. The potassium remains at 3.4. History reviewed, because the second time the potassium coming low, you go back. History reviewed. Father died of CVA at 41. So now, because of this association, because of hypokalemia, which was persisting, initially, as you can see, there was this diuretic there, which was thought to contribute to the hypokalemia, and then the diuretic was taken off, and the patient was put on olmesartan and amlodipine. And in spite of being on an ARB, the potassium was 3.4. So the aldosterone was assessed, the PAC-PRA ratio was assessed, and as you can see, the aldosterone levels were quite high. And then the CT abdomen was done, which showed a mass in the left adrenal area. ONDST was negative. Urinary metanephrines were normal. Diagnosis was primary hyperaldosteronism. And a surgical resection was done. Antihypertensive reduced, and OHA was also, antihypertensive stopped and OHA was also reduced. So does hyperaldosteronism cause diabetes? Actually, the prevalence of primary aldosteronism in type 2 diabetes with resistant hypertension has been defined to be around 14%. And that means 14 out of every 100 patients that you're seeing in the OPD. 100 patients for us, I think those who are practicing in India, we see 100 patients in 2 days or even lesser perhaps. So out of these 100 patients of diabetes, 14 people could be actually having the ones with resistant hypertension, they could be having the primary hyperaldosteronism. And they are, missed quite often. These are the mechanisms theoretically, put forward, because Aldosterone induces hypokalemia. Hypokalemia causes the impairment of the glucose tolerance by impairing the insulin secretion. However, once you correct the hypokalemia by the potassium supplementation, only partial resolution of the insulin secretion and glucose tolerance occurs. Aldosterone per se also impairs glucose-stimulated insulin secretion in the isolated pancreatic islets in a mineralocorticoid receptor-independent manner. Apart from that, it suppresses the glucose uptake at the peripheral level. It may produce insulin resistance secondarily by increasing the inflammatory cytokines, and excess aldosterone and MR activation. We know that affects the vascular function by reducing the nitric oxide, and bringing about hypertrophy, vascular hypertrophy, and others. So this is what hyperaldosteronism does to in terms of the skeletal insulin sensitivity, pancreatic beta cell function, inflammatory adipokines, hepatic gluconeogenesis, all in all leading to a metabolic syndrome and a diabetes state. We know these trials have told us that interruption of the RAS prevents the occurrence of diabetes. The DREAM trial and the Navigator, Ramipril and Valsartan. So this probably explains that you bring a decrease in aldosterone and subsequent mineralocorticoid activation brings about a decrease in the risk. And that's the same that happens with the resection of the aldosterone secreting tumor and thereby the resolution of the blood sugar levels. So the last case here, or the second last, I guess, is about a 79-year-old man, diabetic for the last 10 years, gliclazide, metformin, starts to feel cold, dizzy, tremors, collapses, BP down, sugar levels 35. Now you would say, okay, my God, 79-year-old, why have you put him on a gliclazide 80 milligram, that too twice daily? So bring down. Everything was brought down. Hypoglycemia persisted. He was treated with 25% glucose with recovery of consciousness. Again, BD from BD to OD, the gliclazide was stopped only on metformin, and in spite of that, his sugar levels kept going down. And then the sodium levels were also assessed, which were low. BP was low, and so he was assessed for hypoglycemia. The insulin C-peptide levels were done. The serum cortisol level was also looked at. That was 3.24. TSH was 7.6. An ACTH sample was sent, and ultimately the patient was diagnosed to have adrenal insufficiency. So, and then he was started on hydrocortisone twice daily, which brought about the improvement. And then subsequently the sugar levels went up, glucose infusion suspended, a CT scan done, adrenal glands were bigger than normal, but there was no evidence of an active tuberculosis, something that is there in the differential diagnosis in these cases where you're thinking of Addison's. But generally the patient was put on just Visolone here, and the glycemic parameters rose, but was controlled with metformin as such. Subsequent follow-up, blood sugar levels controlled, vital stable, and TSH normal. So adrenal insufficiency, also the opposite side, of just to discuss, because we're discussing about how the adrenal is affecting the, the glucose metabolism. I just thought I'll bring this in because a lot of times, patients go into hypoglycemia and you know it when you're talking about, again, as I'll say, in an adrenal seminar, you know the answer. But when you're sitting in your clinic, a lot of times you tend to miss it. And that happens to all of us. So, the rule of the thumb, unexplained hypoglycemia, the diagnosis of Addison's disease should be considered after excluding the other causes of hypoglycemia. Last case is a 16-year-old boy, type 1 diabetic, last 7 years on insulin pump. 4 months back, his TSH was 9.8, anti-TPO positive, therefore LT4 at 50 was initiated. He presented with 3 episodes of hypoglycemia in the preceding 3 months. One of these episodes was severe. Type 1 diabetes, hypothyroidism, anti-TPO positive, you would treat. So what happened? Why did the patient, subsequently go into hypoglycemia? So here the blood pressure was coming down, a reduction in the insulin dose. You assess the patient's food diary, nothing significant had changed, re-evaluated. Why is this patient having hypoglycemia again and again? And then the third one had seizure. Body weight was unchanged, BP was going down, HbA1c came down. So when eventually the reduced basal insulin, the insulin came down, subsequently patient became gradually became asthenic. Now weight loss was observed. Now the downloaded data of the insulin pump showed a major reduction of total insulin by more than 30%. BP was coming down even lower than the previous visit. So now it's 80 by 50. Sodium low, potassium high, cortisol 1.5, ACTH at 1274, CT abdomen small, non-calcified adrenals. Diagnosis, Addison's disease. Patient was a type 1 diabetic, initiated on thyroid medication because of the hypothyroidism, because subclinical with a positive anti-TPO, and we know what that did. The thyroid, once initiated, increases the metabolism of the cortisol to cortisone, the inactive form of cortisol. And this was a boy who was standing at a threshold level. He was somehow maintaining his cortisol levels, but once the thyroid hormone was initiated, because of the increase in the activation, he, the whole thing collapsed, the whole system collapsed, and the Addison's disease presented itself. So we must remember in type 1 diabetics, when they are being treated, the autoimmune disease, this needs to be kept. So on that basis, I will just keep the DHA out of the discussion. This is my last slide. Adrenal and diabetes, do they have a connection? So just look at the connection. Whether you're talking about FeO, or you're talking about the hyperaldosteronism, the Cushing's, or you're talking about the opposite end of the spectrum, it's adrenal insufficiency. The connections are multifactorial, pathway connections, and yet how many of them are diagnosed? How many of them are treated? So there could be a lot of your patients, your diabetics, your hypertensives, who actually have an adrenal cause to their diabetes or the hypertension, and which should actually be resolved with the correct treatment of the cause. And on that note, I stop sharing my slides and I'll hand it back to Beatrice. I think I've overshot my time.
No, you didn't. You're exactly on time. Okay. Thank you so much, Dr. Arundhati, for that wonderful presentation. Personally, I feel a case-based approach is like the best way to get your message across. And you have really shown us some wonderful cases. And what we understood from your presentation was that adrenal diabetes is something which is probably underdiagnosed. And we really need to have a high index of suspicion in these cases. So let us take this discussion further. And okay, not able to share my screen. Can the technical team please help? Yeah. Is my screen visible?
Yes, ma'am.
Yeah, thank you so much. So let us move on to the panel discussion, and we'll invite our panelists to share their knowledge on this topic. But before we go ahead with the panel discussion, let's have a few fun facts. The question courtesy is, of course, Dr. Sanjay Kalra. So questions for the audience. Which abortifacient is approved for adrenal hyperglycemia? And question number 2, which catecholamine modulator is approved for type 2 diabetes management? Keep thinking of the answers while we go ahead with the panel discussion. I'll tell you all the answers at the end of the panel discussion. So let's invite our panelist, Dr. Douglas. So sir, is the management of adrenal diabetes different?
Oh, hi, sorry. Well, the management depends on the person's type of diabetes and whether they are deficient or overproduce of cortisol. In the Cushing syndrome, we can see an increase of insulin resistance, and in adrenal insufficiency, we see symptoms that are confused with those of the lack of control of diabetes. I think it will always be necessary to make individual adjustments to the treatment. So, should the treatment could be different? Yes, because of the characteristics of every disease, and probably it will be much different with people with Cushing syndrome.
Thank you, sir. So let me ask the next question to Dr. Raman. So, sir, we do see patients with diabetes and an incidentally detected adrenal adenoma. So, how do we connect the dots between diabetes and an adrenal incidental? So, you need to unmute yourself.
Yeah, good evening. So there appears to be a definite association between adrenal incidentoloma and type 2 diabetes. Adrenal incidentoloma has been shown to increase the risk of diabetes. So multiple prospective and retrospective studies have documented this. Just to quote one study published recently in JCEM 2020, it's a prospective study where they studied 600 patients coming from OPD setup to the radiology department for CT abdomen evaluation for various reasons. So after excluding the patients with a history of adrenal disease and tumors, they found the prevalence of adrenal incidentalomas in this study to be 7.3%. That's 44 out of 600 patients turned out to have adrenal incidentalomas. When they further analyzed the data, they have shown that this adrenal incidentoloma has been associated with increased BMI, male sex, increased waist circumference, and most importantly, type 2 diabetes. So the link, the association was very strong between adrenal incidentoloma and type 2 diabetes. So they found that 31% of patients with adrenal incidentalomas had diabetes compared to only 15% of those who did not have incidentalomas. So there was a striking difference between the two groups. And they also performed the dexamethasone suppression test to see whether they are having autonomous cortisol secretion. So it was seen that 50% of them had post-dexamethasone suppression cortisol was more than 50 nanomole, that is more than 1.8 microgram per deciliter, indicating that they are having possible autonomous hypersecretion. But the incidence of diabetes was not different between the two groups who had suppressed values and who did not have suppressed values. They also analyzed the effect of increasing age on the association between incidentoloma and diabetes. So when they analyzed the incidence of diabetes and adrenal tumors by age-wise distribution, the association was not linear, indicating that increasing age alone may not explain the association. So similarly, another retrospective longitudinal study also documented the increased incidence of diabetes on follow-up in patients with adrenal incidentalomas. They had documented increasing incidence in diabetes compared to those who did not have incidentalomas. And lastly, a meta-analysis which analyzed the morbidity and mortality patterns of the adrenal incidentoloma patients documented that the type 2 diabetes prevalence was twice as high in patients with adrenal incidentalomas who was having autonomous cortisol secretion. Now, they also noted that in those with non-secreting adenomas also, the incidence of diabetes was higher than general population. So there is definitely increased incidence of diabetes in adrenal incidentalomas, but the possible link between the two again appears to be insulin resistance. So as Dr. Arundhati also mentioned in the presentation, 20% of these adrenal incidentalomas can have autonomous cortisol secretion. So this can increase insulin resistance and followed by the hyperglycemia and type 2 diabetes. And even in the so-called non-secreting adrenal incidentalomas also might be secreting the adrenal steroids or their metabolites, which are not currently detected by the currently employed assay methods. So detected only by LCMS, which is rarely used to estimate these steroids. So that might be a reason for them to increase insulin resistance, again, causing hyperglycemia, type 2 diabetes. So there's a strong link which has been established between the adrenal incidentalomas and diabetes.
Thank you, sir. That's very good information about the association between adrenal incidentalomas and diabetes. So let me ask Dr. Arundhati, you were discussing about your cases where, after the diagnosis of the adrenal lesions and the treatment of the same, there was a reversal of the diabetes. So is this sort of adrenal diabetes always reversible after the treatment of the adrenal cause?
So if you would remember, Dr. Beatrice, in one of the slides where we had looked at those studies published, which have been across the years from the 1960s to 2017, most of them, not all of them, but most of them did say that patients had no requirement. But some of them, yes, the patients were continued on either metformin or maybe one more sulfonylurea, but at a much lower dose. And remember, these were mostly patients who had a very high requirement pre-surgery. They were on OHAs, they were on insulin, and then it majorly went down. But we also need to remember one more thing, that when we're talking about diabetes and the adrenal, we're talking about the secondary diabetes out here, but we must also remember it could just be per se type 2 diabetes mellitus who also has an adrenal cause, right? Which is probably exacerbating the sugar levels, which is exacerbating the hypertension. So once you take away the adrenal cause, these patients are not going to absolutely revert back. Also, I was going through one of those articles where they said it would also depend on the number of years, because a patient has been say subclinically Cushing for a number of years. So the insulin resistance, the hypertension, the vascular changes that have been brought about, these will not immediately reverse once So hypertension doesn't always reverse, excepting for hyperaldosteronism, where the reversal is quite good. Diabetes, in most cases it does, but not always. So it varies from patient to patient. But the requirement definitely comes down substantially.
So sort of depends on their underlying risk for type 2 diabetes, like family history and presence of obesity, and not just primarily the adrenal cause.
Yeah, absolutely.
So yeah, thank you, Dr. Arundhati. So Dr. Raman was telling us about this association between adrenal tumors and type 2 diabetes. So Dr. Douglas, what is your opinion? Is there any association between non-functional adrenal tumors and diabetes?
Well, adrenal tumors are commonly discovered on abdominal imaging. The majority of adrenal tumors are classified as non-functionals and considered to pose no health risk, whereas a minority will be considered functional because they secrete hormones that increase risk for metabolic and cardiovascular diseases. Individuals with apparent non-functional adrenal tumor, as defined by current clinical guidelines, have, according to what we've seen, approximately twofold higher risk for developing incidental diabetes when compared with patients without adrenal tumors. Further, a potential mechanism underlying this increased risk for diabetes may be glucocorticoid excess within a range that is currently normal by our accepted standards. In this regard, non-functional adrenal tumors may not be non-functional after all. Rather, they may secrete small and inappropriate amounts of glucocorticoids that increase the risk for metabolic disease over time.
Okay, that's a very important question you have raised, whether actually they are non-functional. So this could be a smoldering disease where there could be glucocorticoid secretion, which we are not able to detect by standard methods. Thank you, Dr. Douglas. So Dr. Raman, can you tell us how does diabetes affect the HPA axis?
Yeah, well, diabetes has been shown to have effect on the HPA axis regulation. So the major abnormalities found in diabetes with regard to HPA axis are elevated basal cortisol, inability to suppress the cortisol with the dexamethasone, and there is exaggerated cortisol response to CRS stimulation. So these changes may indicate abnormal feedback inhibition of the HPA axis. So this has been postulated to be due to the direct damaging effect of diabetes on hippocampal region of the brain. So hippocampus is known to play a major role in the regulation of HPA axis. So diabetes early on in the course of disease, the hyperglycemia can cause damage to hippocampus by reducing the glucocorticoid receptor density in the hippocampus. So hippocampus has been shown to have maximum localization of insulin and glucocorticoid receptors in the brain. So this forms the link between the diabetes and its effect on the HPA axis. So by damaging to hippocampus and reducing the receptors, this reduces the feedback, stimulation of the feedback inhibition is reduced. So this may increase the cortisol levels. So further on, the hyperglycemia together with chronically elevated cortisol levels, may further have deleterious effect on the hippocampal function. So this may form a vicious cycle, causing dysregulation of the HPA axis. And it has been shown that this effect of diabetes on HPA axis dysregulation is graded. The more severe hyperglycemia, the more effect on HbA dysregulation. So the association between the HbA1c and HPA axis dysregulation has been constant after adjusting for other variables like BMI, hypertension, dyslipidemia, which indicates that there may be a direct damaging effect of diabetes on HPA axis regulation. Then what is the mechanism of this diabetes in causing HPA axis dysregulation? So again, it is postulated that the insulin resistance by causing endothelial dysfunction. So this endothelial dysfunction may result in functional hypoglycemia during the periods of excess glucose demand, that is during brain activation. So this functional hypoglycemia together with elevated cortisol levels might be having a damaging effect on vulnerable regions like hippocampus. So this probably is responsible for the dysregulation of the HPA axis due to diabetes. And this may clinically manifest with the cognitive deficits. The neuropsychological testing in these patients has been done to document the memory deficits due to probably the dysregulation of the HPA axis due to hippocampal damage.
Thank you, sir, for explaining so beautifully the mechanism behind this disruption of the HPA axis in diabetes. So we were talking about diabetes and adrenal tumors. So Dr. Arundhati, can you tell us, is there any link between insulin and adrenal steroidogenesis?
Yes, there's a strong link between insulin and adrenal steroidogenesis. Initially, remember, Dr. Beatrice, if we look at the older studies published, they were talking about insulin and ovarian steroidogenesis, which is the pathophysiology that we identify for PCOS initially. But over the years, there has been an increased understanding that insulin not only affects the ovarian steroidogenesis, but also the adrenal steroidogenesis per se. And that has been explained through a number of factors. There's been talk about the upregulation of the SF1 genes. There's been talk about the upregulation of the the other genes which are responsible for the ACTH-induced stimulation of the steroidogenic path cycle, as also the increase in the mRNA of the various enzymes involved in the pathway. So a number of speculations have been put forward. A number of studies have looked into this and have definitely found an association. Now I'll also talk about the opposite thing. There's also been an association between hyperinsulinemia and adrenal mass. I'm not talking about steroidogenesis per se, but an adrenal mass, which has been attributed to obese people, hyperinsulinic people, because of the increase in the IGF-1. There has been just been said that that could be causing a mitotic effect and thereby causing a functioning or a non-functioning adrenal mass. So there have actually studies which have conducted. There's a big series which has looked into this, the association between hyperinsulinemia and adrenal mass per se, keeping aside the steroidogenesis part also. So yes, very strong association is there between insulin, hyperinsulinemia, adrenal gland in terms of an increase in the mass in terms of an adenoma, or as also in terms of increase in steroidogenesis. Whether it is manifested or not, that is again a controversial issue, because a lot of studies have said yes, but it doesn't go because it upregulates up to the 17 OHP and not beyond that, because 1720 lyase is downregulated. That is what is said. But then again, there have been other studies which have said that yes, there is a little bit of increase in the adrenal androgens as well. So yes, there is an association between these two.
Thank you, Dr. Arundhati. Now, ma'am has told us about the link between insulin and adrenal masses. So we're talking here about adrenal hyperactivity. So Dr. Douglas, what is your opinion? Can metabolic syndrome be considered a part of the spectrum of disorders associated with adrenal hyperactivity?
Well, similarities between the metabolic syndrome and Cushing's syndrome and the reversibility of the features of Cushing's syndrome suggests that cortisol may contribute to the pathophysiology of both conditions, and that reducing cortisol action may provide a novel therapeutic approach in the metabolic syndrome. there is substantial evidence that circulating cortisol concentrations are higher in people with hypertension than glucose intolerance. The basis for this activation or hyperactivation of the hypothalamic pituitary adrenal axis remains uncertain, but it may be attributable to programming effects of events in early life. For instance, this has been seen in people who are born with early in life, not 38, 40 weeks, but with the 30 weeks and 26 weeks of pregnancy.
Thank you, sir. Mr. Dr. Raman, could you share your opinion? Is there any role of insulin in the pathogenesis of adrenal masses as such?
Yeah, the insulin again appears to have a role in the pathogenesis of adrenal masses. So the insulin resistance by causing compensatory hyperinsulinemia, which can upregulate the IGF-1 receptors, allowing the insulin to bind to IGF-1, and also hyperinsulinemia by increasing the GH receptor action in the liver, leading to excessive production of IGF-1, and simultaneously this hyperinsulinemia by causing downregulation of IGF binding proteins, it will cause increased availability of IGF-1 and IGF-2. So these are having mitogenic effects on the adrenal cortical cells through multiple pathways like MAP kinase pathway. So this can increase the adrenal cortical cell growth, leading to tumor formation. And as such, the diabetes also represents a risk factor for multiple types of cancers through other pathways also, like increased production of tumor necrosis factor alpha from adipose cells, which also may play a role in the tumorigenesis in various organs. So definitely hyperinsulinemia has been implicated in the pathogenesis of adrenal masses.
Thank you, sir. Dr. Arundhati, you had mentioned in one of your cases, in fact, a patient with hypoglycemia, with type 1 diabetes. So is there any association between diabetes and a hypofunctioning adrenal gland? Do we need to rule out any syndromes? And while we are at it, can you also tell us the association between diabetes and multiple endocrine neoplasias?
So the association is stronger with type 1 diabetes and a hyperfunctioning adrenal gland, as like the case that we were discussing, diabetes, hypothyroidism, autoimmune, type 1 diabetes, autoimmune hypothyroidism, and Addison's disease. We know that there's this syndrome known as the Smith syndrome. So why this is very important also, I think, Dr. Beatrice, is because a lot of times we are treating type 1 diabetes patients with hypothyroidism. But in how many of them are we looking at the cortisol level? Because since this is, it's a rare syndrome, definitely it's a rare syndrome. It's something around 1 in 2 lakhs or something. I think even rarer, but definitely that, that patient could be your patient, right? So I think it's always better when you're treating the hypothyroidism in type 1 diabetic patients, get a serum cortisol level done. There is no harm. When you've got 2 autoimmune diseases, there's no harm in ruling out the third one, because your initiation of your, thyroid hormone could spell, a big problem for you if the patient has a hyperfunctioning gland. If you're talking about multiple endocrine neoplasia, yes, we are talking about MEN1 because of the increase in gastrin and thereby the changes brought about, or you're talking about MEN2, where because of the presence of FeO, obviously there could be a connection with diabetes because of the presence of hyperparathyroidism. That could also secondarily lead to an increase in alteration in the metabolic spectrum. Also, if you're talking about the presence of paragangliomas, and there again you're talking about something very similar to what is happening in the FeO. So in all these syndromes, you could have diabetes, and we have had case reports wherein you had patients presenting with diabetes and eventually found to have FeO and the others. I had just discussed the cases which presented as FeO only. This could well be cases which are a part of the MEN syndrome. So definitely the other areas also need to be ruled out for these patients. So these connections need to be remembered. I think we tend to forget. I always want to stress on is the clinical importance of whatever we are discussing, because we tend to forget. We'll remember it. We have remembered it in our DM lectures. We have remembered in our answers, but we tend to forget in our clinics. So that's why we need more of discussion of these rarer things, because for us it's a rare case. for that one patient, it could be a difference between, living life and surviving life.
Yes, true. Thank you, Dr. Arundhati. So let's get back to our fun facts. So which abortifacient is approved for adrenal hyperglycemia? It is mifepristone, which in higher doses acts like a glucocorticoid receptor antagonist. And which catecholamine modulator is approved for type 2 diabetes management? It is bromocriptine, which is considered to be a centrally acting anti-diabetic agent. And it sort of resets an abnormal hypothalamic drive, and it reduces the sympathetic tone in patients with diabetes. So with that, we come to the end of the webinar. I would like to thank our speaker, Dr. Arundhati, for that excellent overview of the topic. I would like to thank our panelists, Dr. Douglas and Dr. Raman, for sharing their insights and knowledge with us. And I thank Dr. Sanjay Kalra, sir, for giving me this opportunity to be a part of the program. And I would also like to thank Samarth Life Sciences for hosting the event. And I would like to thank each and every one of you who has participated here today in this webinar. So thank you all, and over to Dr. Kalra, sir, for the closing remarks.
It's been a great day today, and we have learned so much. Thanks to our panelists, Dr. Douglas and Dr. Raman, for being with us. Thank you for your pearls of wisdom. Dr. Douglas, it's great to have you with us. This was an visit to India. We hope to have a real one in the near future.
Thank you so much.
We'd like to thank Dr. Arundhati. I think a lot of energy went into preparing that talk. So Arundhati, what happened to your adrenal hormones while you were preparing that talk?
I hope my sugar levels did not rise, sir.
when Beatrice gave you the topic, what happened to your hormones at that time when you received the topic in your mail?
We'll discuss it some other times.
Later. So, Dr. Beatrice, as always, thanks to you. It's been a great show. We'd like to hand over to the team from Samarth, Prashant and Mr. Pandita. And thanks to everybody who's logged in with us today.
Yeah, Prashant. Sir, before Prashant starts, there is a little correction because I thought it is 20 milligram. You are right. 3 rupees and 60 paisa is the cost for 5 milligram, and 6 rupees and 20 paisa for 10 milligram.
Yeah.
Yeah. So it is 15 rupees for 20 milligrams, sir.
We have a global audience today, and Samarth is the manufacturer of perhaps the most economical hydrocortisone and fludrocortisone in the world. And with $1 American, you can get something like 14 or 15 tablets of 10 milligram of hydrocortisone.
Correct, sir. Yeah, Prashant, please.
First of all, I would like to thank all the delegates and panelists who have joined us for today's webinar. With today's webinar, which happens to be the 6th webinar this year, we mark the end of EPIC 2021 chapter. This year, we covered a diverse range of topics around adrenal disorders, including Addison's disease, exogenous Cushing's, primary hyperaldosteronism, pheochromocytoma, adrenal obesity, and today, adrenal diabetes. Diagnosis and management of adrenal disorders is often challenging. Hence, more emphasis and importance is inclined towards the clinical acumen of the treating physician, often the primary healthcare provider. It is imperative that there should be more and continual experience sharing among the medical community. It is precisely for this reason we started with this webinar series on adrenal medicine under the banner of EPIC. On behalf of Samarth Life Sciences family, I would like to extend our heartfelt thanks to all our esteemed panelists and delegates who have taken time from their busy schedule to attend today's webinar on adrenal diabetes. We'd like to also express our sincere gratitude towards our national conveners, Dr. Sanjay Kalra, Dr. Rakesh Sahai, and Dr. Ganpati for helping and guiding us to organize this series of webinars on usually less discussed adrenal disorders and adrenal medicine. A big thank you to all of you from Samarth Life Sciences family, proud to be the only manufacturers in India of Izone tablets and Floricort tablets, that is hydrocortisone and fludrocortisone. Stay safe, stay healthy. Thank you very much. And we'll see you again next year, 2022, with another 6 topics and 6 webinars on adrenal medicine.
That all depends upon Dr. Kalra, sir. How you can shape up.
Now there is the new team. Beatrice and Arundhati will take the torch forward.
Right. Yeah. But your guidance is needed, sir, everywhere.
Right. Thank you.
Thank you, sir. Thank you. Thanks all. Thank you.
Bye.
Bye.